apologize. I'm in a hotel in Spokane just after skiing, so there may be some noise. The good news is that when you look at what the other speakers said, I agree 100% with everything they said. The difference is that we have more information from the standpoint of the kidneys and people with chronic kidney disease, but otherwise our message is the same. I guess, I'll just ask questions now that we'll discuss later in the panel, but, my interest now is, which medications work differently, especially the vasodilators and their impact. I mean, as you can see, Doug listed a lot of medicines that are in the vasodilator, camp, but they're not pure vasodilators. And so the question is, and I think in our case, we found that we need more potent vasodilators for the people who are vasoconstricted. And so, for instance, just using, ACE inhibitors, ARBs, are not enough really for most of our patients who are vasoconstricted. And of course, because people with chronic kidney disease mostly are on ACE or ARBs, they're already coming to us with uncontrolled hypertension on maximal medications for this. The other question I have is really about the volume overload, because neither author, had that listed as a category of treatment. But, I would agree with them on that, but it's something I'd like to discuss further, why we're not seeing, even in people with kidney disease, volume overloaded people. So this is really no different than, what Doug said, very poor control. If it's bad, in primary care, it's even worse in nephrology because we get referred patients with poor blood pressure control, and people with chronic kidney disease are often on as many as 4 antihypertensives without good control. So, the more pills you're on, the less compliant you are. So for us, this was a really dramatic change where we could really tailor down their medications, allowing them to have better compliance. And so that was, really important. And also the fact that no blood pressure medicine has been proved better than any other. So it makes sense to individualize it. And I'd say the last thing that we have a little different than the rest of the group is that we have always used central blood pressure, sphygmocor, and that gives you some more information. And in our publications, we discuss how the results of NICAS guided blood pressure control would impact on the central hemodynamics with sphygmocor. The other advantage of the sphygmocor is it gives you 3 validated blood pressures and averages them. And so it really gives you the gold standard for office readings. The other thing that we've done is we've paired it with home blood pressure monitoring, with remote monitoring that comes back to our office, where we can monitor the patients after switching their medicines, and also having come back for follow-up readings with the NICAS and the sphygmocor. That would be something I'd also want to ask Doug, is what kind of follow-up they have in terms of seeing the effect on the hemodynamics after tailoring their blood pressure medicines. So this is just repeating what the other authors had said. Only 3 reasons you can have high blood pressure: vasoconstriction, hyperdynamic, high volume, or a combination of them. Same kind of information. Now this is dialysis patients who are even worse than the general population. And again, a lot of, what I've been interested in our research is the idea of going to personalized and individualized medicine, and, treating the patient as an N of 1 rather than as a group. And I think that will have a dramatic change in how we manage people as we go forward. So this was our study. This is doing the same thing that really Doug did, same sort of approach. And we did this in a office-based nephrology practice, which has mostly CKD, but also people referred for uncontrolled hypertension. So kind of the most difficult patients to treat. And they would all get, everybody in their office would get enrolled in the study, and they would get the central blood pressure, give us pulse wave velocity, also 24-hour blood pressure monitor, impedance cardiography with the NICAS. And the way we did the study is more, real world type thing. So two of us used the data to guide our treatment. The other doctors really didn't look at it, but we did get the data on the people that were not being in the treatment group. And then follow-up studies were done 3 weeks after the medicine change. And the same thing as Doug in terms of how we would manage these people. And this is our results. So these are people already theoretically getting intensive blood pressure control and being treated by a specialist, and they had such poor blood pressure control to 140/90 or below 130/80. But you can see that 81% of the patients were under poor control, and by the time we finished the study, we only had 15.4% that really didn't meet goals. So I think we thought this was pretty impressive considering our patient population. And this is just the reference, the tables we had in the paper showing the percent people vasoconstricted, so 41% or 45%, mixed 18%, and hyperdynamic alone 41%. And really, again, we didn't find much in terms of the volume, interestingly, and I'd be interested to hear comments from other authors about that. But after, we looked at the control versus the treatment group in follow-up, we had highly significant improvement in the blood pressure. And you can see it also had effects on the hemodynamics, particularly peripheral vascular resistance. We did see effects on arterial compliance with the sphygmocor data. We also saw improvement in that in the people that we treated. The algorithm similar to Doug's algorithm. And this is an example of 32-year-old hypertension, systolic heart failure, CKD, hyperaldosteronism, edema, focal sclerosis. I mean, with a history of a stroke in a 32-year-old. Yeah, that's our average patient in nephrology. Thank you. And you can see what happened was that, again, on 4 medicines, typical for a CKD patient, and after NICAS and seeing the patient was vasoconstricted with a decreased cardiac output, which, by the way, I'd emphasize that most of these people who are vasoconstricted as a pure, group, they were also had a decreased cardiac power or stroke index. And then if you vasodilate them, you'll see the cardiac output increases here. So if we look at the right graph, you can see the cardiac function going from very poor actually to the low normal range in a person with known systolic heart failure. And you can see he was going from the vasoconstricted group eventually into the normal group. And so we did that by, maximizing the lisinopril, increasing the nifedipine actually below the, the accepted dose, which we sometimes do in people with chronic kidney disease, people with poorly controlled hypertension. We will go to an above accepted dose of vasodilators. And Also, the lisinopril went above the dose, and we decreased the beta blocker, stopped the spironolactone, all medicines that often are used in heart failure, but we got them up to improve cardiac function just with those approaches. And like Doug, we give the patient feedback, and I learned this from Doug actually, that when we say they're vasoconstricted, we use our hand like a fist and go like, your blood vessels are tight like this, and we're giving you a medicine that's going to relax them. Very powerful message to the patients. I don't know, but I think it improves compliance because they know why they're taking the medicine. They know what's wrong with them, because blood pressure is a silent disease, as is kidney disease. So, you have to really convince the patient they have a problem, and they don't feel any different, often feel worse when they're on blood pressure medicines. So you have to give them feedback to show that, they're doing better. And then we show them in follow-up. You can see the red dots were where they were, and then we significantly improved their peripheral vascular resistance, and their cardiac output goes up. So thank you for allowing me to speak, and I'll answer questions with the rest of the panelists.